So the House of Alzheimer's disease has many windows that patients and caregivers can look out of. The window of repetitious questions, functional losses like getting lost while driving, unpaid bills, a botched Thanksgiving meal, neuropsychiatric symptoms like agitation, apathy, depression. Many windows to look out of, but just one door to enter the house of Alzheimer's disease. And it's a door called dementia. And behind me are two icons of this disease. She is Auguste Dieter, Mr. Dieter's wife, who would no longer cook him dinner and keep the railroad clerk's house in order, and so he brought her to see Dr. Alzheimer's, who diagnosed her with his unusual disease of the cerebral cortex that would later acquire his name. He, in the lower right-hand corner, the smaller icon, is Stephen Hume, a more contemporary patient who has become an advocate, serving on Alzheimer's Association boards and speaking of his experience of being a patient with Alzheimer's disease. After his diagnosis, he said that this is what he did. He said that I closed my eyes and I could see a room full of open doors with sunlight outside, and all those doors then shut, and I was in the dark. His Alzheimer's doctor said, your world will progressively shrink until it becomes the size of the chair you're sitting in. To enter the house of Alzheimer's disease, an Alzheimer's doctor like myself has to diagnose and label you with dementia. Until now. Now, in the 21st century, society is hard at work remodeling the house of Alzheimer's disease. We have a National Alzheimer's Project Act whose goals include the discovery of effective preventions and treatments by 2025. And the United States Congress has steadily increased the amount of funding it's putting towards that goal, as much as in the last budget, an additional $300 million towards that goal. We're going to build new doors to enter the house of Alzheimer's disease. We'll build a door called mild cognitive impairment due to Alzheimer's disease. And someday soon, perhaps, the door called preclinical Alzheimer's disease, a stage of the disease defined not by an expert bedside clinician's assessment of the patient's signs and symptoms, but an expert desktop practitioner's assessment of the person's biomarkers of neurodegeneration. Measures, for example, of amyloid done with a PET scan, or tau, or neuron death and dysfunction. The biomarker, she's a bride still waiting in the foyer, though, to enter into the house of Alzheimer's disease, waiting for her groom who will lead her in. And that groom, who she's yet to find, is a drug. And the ceremony they'll have that will marry them is the clinical trial, the experiment. Pardon these metaphors, and I'm comfortable with two grooms or two brides, whatever it may be. But what they do is they serve to make the point that diseases are not real, but diseases are real, but the illness and the labels are at our hands, our construction. We build and we remodel what we talk about when we talk about Alzheimer's disease. And in the new house of Alzheimer's disease, will be built by experiments that show a drug changes the natural history of the disease. The drug will be conjoined to the biomarker. And the term of art now that is used in the field is called a theranostic, a therapeutic and a diagnostic conjoined, a theranostic. That is the marriage of the test and the drug. It's a model that actually has been used before and created. Hypertension. The disease is defined by the number, the measure, the drug that changes the number, and the outcomes of things like stroke and heart attack. Cardiovascular disease, defined by the drug that changes the marker, cholesterol, that changes the natural history. Osteoporosis, defined by the measure of the density of the bone, intervened on a drug, etc. And someday soon it may create the new house of Alzheimer's disease. And I've told you about NAPA, which has its goal to prevent and develop effective treatments by 2025, and the tremendous investment that we are putting into that goal. And I'll talk later about some of those trials. In Europe, the European Prevention for Alzheimer's Disease Initiative is soon to launch with a similar set of goals and a trans-country investment. So how are we going to live in this new house of Alzheimer's disease? And I think to begin to answer that question about living in the new house of Alzheimer's disease, we want to think about it at the level of the individual, the level of the profession, and also at society. And so I think when we want to answer that question, we have to incorporate multiple perspectives. Perspectives of ethics, social psychology, sociology, anthropology. And why is that? Because I think we should consider who are the builders of this new house of Alzheimer's disease. Once upon a time, the builders, the keepers of the new house of Alzheimer's disease were people like me, expert clinicians, skilled at the bedside, history and physical, a backward-looking, essentially narrative exercise to make sense of someone's story of suffering. What's the problem? Why are you here? How can I help you? Now, the new profession are these desktop clinicians who are skilled at correlating the actuarial to the clinical, skilled at parsing a person's risk, their future history of what will happen to them. Through them and with them are their biomarkers and their drugs, their theranostics. Now, these things, of course, are owned. They do not simply denote a treatment, but its very definition along a continuum of cognition and function. In a sense, Alzheimer's is about ready to have a business model. Alzheimer's disease will be owned. And as Jesse pointed out, events such as the Bayh-Dole Act, which allowed the ownership of discoveries made with NIH funds, are among the key past events that make this new world possible. And so the C-suite's rhetoric to market and promote their drugs and the tests, particularly those that are conjoined together, that rhetoric will shape the language, the culture of what we talk about when we talk about Alzheimer's disease. So the stakes are high and they're different, very different from the world that, in the house that we've lived in. So let me think about it at the level of the individual. So now what we'll be presenting to individuals is the knowledge that their brain is at risk, that it stands to decline over time. And so what you begin to create is the potential for kind of a looping effect between the label that you then give and the mind that holds that label, creating opportunities, for example, for a stereotyped threat to that individual, that there will be decline and therefore there is decline and therefore there will be decline. What will people tell other people as they gain and acquire these labels? How will others treat them, especially in the workplace or the corporate suite or the floor of the US Senate, when people start to talk about that they have the markers of degeneration and may or may not be experiencing that. And we're starting to look at this question in our lab. We have several studies now that are piggybacking onto these various prevention trials. One of them, for example, is a study we call the Socrates Study, the study of knowledge and reaction to amyloid testing. And what we're doing is interviewing older adults, 65 to 80, cognitively normal by the current standards of what is normal, not a billable diagnosis for any impairment. And we're interviewing them after they learn their amyloid PET result that tells them that it's elevated or that it's not elevated. And then we're going back and interviewing them about 9 months later. And we want to find out who they talk to and what do they talk about and how does that experience shape their world, their life space. One of them told us, I don't want to worry them, my children. And plus, I think my children may start building that into the way they interact with me. I don't want that. They're my kids, and I don't want them to filter my interactions with there's a possibility that I'm demented. That is the new world of living in the house of Alzheimer's. There's an irony in some sense to the challenge that we're facing. Alzheimer's disease, as Jesse pointed out, became thoroughly a disease in the 20th century because it thwarts our ability to practice a very cherished but late ethic into our culture. Finally, in the 20th century, did we thoroughly permit self-determination through autonomy as an entitlement to being a human, not just on the basis of your gender or your race or where you lived, but your ability to self-determine was something that was owed to all humans. And with that ethic, a disease that takes that life-building ethic away, that self-building ethic, becomes thoroughly a disease. And yet, as I hope I've provoked you, that in our effort to prevent this loss of self-determination, we actually now face, ironically, a threat to the very same autonomy, as spoken by the person who doesn't want to tell her children about the result of her amyloid PET scan, because it will change the way she can and they self-determine her life. It's a curious side effect or risk that's really hard to incorporate into the label of a drug to treat a biomarker-driven diagnosis of Alzheimer's, and yet it's a very real risk. Another question we need to think about in the new house of Alzheimer's disease is, how will we die of this disease? As we reach the end of the era of living Alzheimer's like the winter, a natural history that we simply have to chart, bundle up, and tolerate, and now enter the dawn of a continuum of risk that we can manipulate, we'll live with a disease that is much like cancer, no longer entirely under nature's course, but our course. So when will someone be dying of the disease, and once said to be dying, how will we provide them the patient-centered palliative care that we're so committed to deliver out of our respect for our hard-won autonomy and its self-determination? When would we be dying of the disease and therefore allowed to die? Stephen Hume, the man who sat in the room full of open doors with sunlight outside, he tried to enter the new house of Alzheimer's disease just a few years ago. He had one of those PET scans that measures amyloid, the plaques of the iconic plaques and tangles. And his results showed that he had no plaques. So what house does he now dwell in? Thank you. I've enjoyed the opportunity. I think I'm the last of the prepared speakers. Is that right? I can maybe take a question or two, and then Dr. Whitehouse will sum it all up. So the floor, I guess we're open for questions. Any questions? Actually, one of the populations that is now named in the National Alzheimer's Plan are individuals with Down syndrome. And there are several federal grants that have been made to test, to develop markers of the decline that is seen as individuals with Downs begin to age into their third and fourth decade and develop cognitive and behavioral changes. And I know of at least one experiment, a clinical trial that's planned to test drugs in those individuals to see if it can change the emergence of those symptoms. And so in summary, the persons with Down syndrome are part of what we talk about when we talk about Alzheimer's from the perspective of our national plan. Yeah. There's a microphone coming right now.
If we have clients or patients in the community that we want to refer to the Penn Memory Center, could you tell us the process to do that, please?
You call 215-662-7810, and you make a new patient appointment. But before you do that, I would go to pennadc.org, and I would click on the link, how to make an appointment, and it describes what we do and how we do it. And you'll see whether or not it's appropriate for someone to come to the memory center. So I'd first look at the website. Yeah. Yes, other questions? Peter has a question. There's a question here, and the microphone is coming from the...
Thanks, Jason. You started, as many of us have been talking about words. I think you said the door to the new world of Alzheimer's is dementia. So,
Well, the door has been dementia.
Has been dementia.
Right, that's how we used to.
The door is going to be through biomarkers and risk factors.
In addition to dementia.
Yeah.
Right.
I mean, the problem I have with that model, as you know, is there's an awful lot of variability in this space, not only about the language, but about the biology. So
Right.
the question becomes, and we both worked on something called apolipoprotein E, which is a risk factor, but it's a remarkably variable one. And so how do you think we're going to get more precise about precision medicine in a way that doesn't make us all a bunch of numbers walking around in this house of Alzheimer's?
So I think we will be a bunch of numbers walking around in the house of Alzheimer's. We will, just like we're a bunch of numbers walking around the house of cardiovascular disease with our 8. I just actually got my first true fasting lipid panel recently, and I got an HDL, an LDL, a total cholesterol, and a non-LDL cholesterol. And each one had ranges and qualitative comments about what my numbers were. So, and that will be the new house of Alzheimer's. We'll have our various measures, et cetera. It'll be more complicated because the brain's a tough organ to measure. I think what's more interesting even is not so much those walking around with their numbers, but those who, like Stephen Hume, won't be admitted to the house because, as you point out, the biology is tremendously variable. And what will be the future Alzheimer's disease? I think there'll be the Alzheimer's disease that is the drug responsive Alzheimer's. Maybe we'll name that after its biomarker. And there'll be the non-drug responsive Alzheimer's. And we'll carve out and recarve what we call and what we say it is. Maybe we'll name it for its markers. Maybe we won't. And I think that history's been written through other diseases. I don't think there's anything uniquely privileged. So it'll be a much more complicated house with many doors to enter, and some people in there, like Stephen Hume, will actually be kicked out because they don't fit our label. Although there's clearly something still wrong with him because he was labeled by an expert clinician as having Alzheimer's disease. He just doesn't have Alzheimer's disease. Any other questions? Otherwise, yes?
So a bunch of us here are physical therapists and occupational therapists.
Right.
And we work in the homes with a lot of people with Alzheimer's, dementia, and other like Lewy bodies, things that are in that same category. But a lot of clients. So for us, and as a physician, what is to go from just dementia to then Alzheimer's, and talking to families, and we get a lot of questions, and they'll also ask us about some of the different, a lot of them are on the Menda, things like that, and studies out there about insulin and other things that are being looked at for that. And, for us, we usually will say, well, those are good questions to ask your physician or your doctor. And,
yeah.
They feel like they're maybe not always getting the best
Sure they're not.
answer.
Right. And why aren't they getting the best answer?
Right. So, and we want to be educated to know, too.
Right.
What's that fine line. But so any thoughts on that kind of stuff?
Well, I'll give you two thoughts. One, practical for you, is there are a few places that I think have tried to summarize what we know and don't know and what the terms mean. The National Institute of Aging has your tax dollars at work, a website called ADEAR, Alzheimer's Disease Education Referral, which is a website of education materials written for the public. And they've got a couple of, I think, pretty decent, the graphics could be a little ginned up, but that's all right, guides that try to explain these terms and their meaning as we currently understand them. I think those are helpful things. They're written for a lay audience. They're not written for a professional audience. And I would recommend them. So that's just to try to get your language comfortable. Because the language is ever shifting here, I agree. The second issue, though, is let's just face a very simple fact. You've got mitotic figures that a pathologist says meet the criteria for cancer. What kind of doctor do you go to? That's a question. Answer it. You have heart failure that's a little complicated. What kind of doctor do you go to? You've got Alzheimer's disease. What kind of doctor do you go to? But why did you kind of go, a neurologist? Because you're not sure that neurologist actually knows what the heck's going on. Same thing with a psychiatrist, and quite frankly, same thing with a geriatrician, depending on the nature and severity of the problem. So we don't have actually a clearly defined and designated concept of an Alzheimer's doctor. And yet we say there are 5 million people, it's a silver tsunami, it's the 8th leading cause of death, it's going to bankrupt America. So if you have that kind of, no wonder you have patients going, and your clients saying, I don't have any answers, because there's no one to give them the answers. And that's just the way it is. And it goes back to why we're paying the price of 25 years of lack of decisions and how to take care of older adults in America. Jesse, you can cut me off whenever you want.